let us start with this topic of general anesthesia. So, guys, general anesthesia means what? General anesthesia means you're making the patient fully unconscious. Unlike other anesthesia techniques where the patient is aware of what is happening, in general anesthesia, the patient is made fully unconscious, right? What we need to understand in general anesthesia is what is the indication of general anesthesia, in which patients we require to give general anesthesia, right? So the indication of general anesthesia is any surgery done above the level of umbilicus, done above level of umbilicus. Example, it could be cardiac surgery, it could be neurosurgery, right? It could be thoracic surgery such as lung surgery, okay? Breast abscess, these kind of cases require general anesthesia, and also laparoscopic surgery. Laparoscopic can also be, if you know lap appendix is there, it can be done under spinal, but again it will cause some irritation due to the carbon dioxide gas. Hence, for all laparoscopic cases, it is preferred that we go for general anesthesia, okay? So, that's the indication of general anesthesia. Right. So now, guys, before going to in what phases we get general anesthesia, how is it given, what happens to the patient and all, what are the drugs used, we will discuss a few things in context of premedication. Remember, guys, before giving anesthesia to the patient, you take the patient into a room which is called as pre-op room. Pre-op room. Okay? Guys, remember, there will be, before in the hospital setting, there will be pre-op room, there will be operation theatre, and then there will be post-op room. So before taking the patient to the operation theatre, we take the patient into the pre-op room and we prepare the patient for surgery and anesthesia. What preparation is done in the pre-op room? In the pre-op room, we give pre-medication. We give pre-medications to the patient. What pre-medications are given to the patient? Okay? Now, guys, for that, first of all, what is the importance of pre-medication? For that, we need to go for a case. Okay? Imagine a patient is there who's posted for her mesh hernioplasty. Under spinal anesthesia. When taken into the operation theatre, the patient's BP is 190/100. Right? The surgeon and the anesthetist both are agreeing that we won't be doing this case under this BP. Why we won't be doing this case under this BP? Higher BP means there might be much chance of blood loss. So they are referring this case, they are basically postponing this case due to higher blood pressure, right? But this was, remember, what happened? So they were postponing this case due to high blood pressure, right? But guys, what was happening as you postponed this case due to high blood pressure and all? So due to high blood pressure, many of the cases were getting postponed, right? So the surgeon was asking the anesthetist that in the PAC, didn't you check the patient was hypertensive? The anesthetist told, yes, I had checked the patient was hypertensive, right? So the surgeon asked him, so did you advise the patient to continue anti-hypertensive medications or not? Anesthetist told, yes, he continued, but still the patient's BP was on a higher side. So due to this reason, many of the cases were postponed. So what anesthetist did is, the anesthetist they decided that before taking the patient into the operation theater, we will check the patient's BP and first we will try to optimize the patient. So first, we should know what is the cause of developing hypertension in the operation theater. Guys, the cause of developing hypertension in the operation theater, even though the person is suffering with hypertension, if he is on antihypertensive or if the person is not suffering with hypertension also, once he's taken in the operation theater, he's developing a high BP. The cause of it is what, guys? The anxiety of the patient. Anxiety of the patient. Due to anxiety, he was becoming hypertensive. So what anesthetists did, before taking the patient to the operation theater, they took the patient into the pre-op room where they gave the pre-medications. In the pre-medication, they gave the patient 4 A's. 4 A's. The first A is anti-anxiety. The second A is anti-emetic. The third A is anticholinergic. And the last A is antibiotic. Antibiotic. These are the 4 A's given, right? So guys, why are you giving this anti-anxiety? And remember, I told you 4 A's. The first A was anti-anxiety. Why do you give anti-anxiety drug? Anti-anxiety drug is given to relieve the anxiety of the patient. Now, what is the drug of choice that could be given as a pre-medication? Anti-anxiety drug of choice or anti-anxiety medication of choice, it is lorazepam. Lorazepam is the anti-anxiety drug of choice. It is basically the anti-anxiety choice that would be given as a pre-medication. So that was relieving the anxiety. Second A is anti-emetic. Now guys, why do you give anti-emetic why do you give anti-emetic as a pre-medication? The patient is already in a fasting state. Why are you giving anti-emetic? Sometimes in a fasting state also there might be some secretions in the stomach. In order to prevent the regurgitation of the secretions, we are giving anti-emetic. In anti-emetic, the drug of choice or anti-emetic of choice or basically most commonly used anti-emetic is metoclopramide. 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 It's the most commonly used anti-emetic drug. Okay. Next, apart from metoclopramide, hyoscine can also be used, guys. Hyoscine can also be used. Nowadays, what we are doing is we are using hyoscine. The reason is hyoscine is not only having anti-emetic property, it also have anticholinergic property, and it also provides maximum sedation. Maximum sedation. Hyoscine. Hyoscine is an anticholinergic, anti-emetic, and also provides maximum sedation to the patient, right? So, hyoscine can also be used. But then, if you're just choosing an anti-emetic, it is metoclopramide. Okay. The third drug that we give is anticholinergic. What is the rationale of giving anticholinergic before surgery? Anticholinergic decreases the salivary secretions. Salivary secretions. Sometimes patient might aspirate salivary secretions. In order to inhibit those secretions, we give anticholinergic. In anticholinergic, there are two choices, guys. One is atropine, other is glycopyrrolate. Which of the anticholinergic should be used in this patient? It is always glycopyrrolate. Both are anti-secretory. Why glycopyrrolate? Why? Because atropine causes much of tachycardia when compared to glycopyrrolate. Okay, when compared to glycopyrrolate. Okay, so remember, guys, drug of choice is glycopyrrolate. Atropine is avoided due to the central side effect of tachycardia. Last is antibiotic. What is the need of giving antibiotic before surgery? Before surgery, we give antibiotics so that we can easily prevent the surgery-induced infection or instrument-induced infection or any nosocomial infection. The best time to give this antibiotic is best time to give antibiotic before surgery is 1 hour before surgical incision. 1 hour before surgical incision. This was also asked. 1 hour before surgical incision. If the surgery lasted for more than 6 hours, if surgery lasted for more than 6 hours, such as Whipple's procedure, long duration surgery, then you have to repeat the dose. In that circumstance, you have to repeat the dose of antibiotic. Almost all antibiotics can be safely given, guys. Almost all antibiotics can be safely given before anesthesia, except what two antibiotics which are not given? Aminoglycosides and tetracyclines. Aminoglycoside and tetracycline. Why, sir, aminoglycoside and tetracyclines? Why they are stopped? Why? Because aminoglycosides and tetracyclines increases the duration of block produced by neuromuscular agents, or basically they prolong the action of muscle relaxant. They prolong the action of muscle relaxant. Come on, guys. Which was the other drug that was prolonging the action of muscle relaxant, which was stopped 24 to 48 hours before surgery? Lithium. Lithium was also prolonged. Okay. So that's regarding what is premeditation. 4 A's. Anti-anxiety, anti-emetic, anticholinergic, and last is antibiotic. Now, there is a term called as balanced anesthesia. Balanced anesthesia. Guys, we are talking about general anesthesia and a few things we have discussed about premeditation. What is meant by the term balanced anesthesia? Balanced anesthesia, general anesthesia is to call as balanced anesthesia due to what reason? The reason behind it is what? In general anesthesia, we give multiple drugs in a titrated form. In a titrated form. Multiple drugs, IV induction agents, inhalational agents, muscle relaxants. You are not depending on a single drug for general anesthesia. You give multiple drugs in a titrated and balanced form that is called as balanced anesthesia. And this concept of balanced anesthesia was given by John Lundy. Funny name, but we have to remember this. Okay? John Lundy. Remember, balanced anesthesia is a general anesthesia only. Okay? Now, guys, we are talking about general anesthesia. Imagine we are having a patient who's being diagnosed with intracranial bleed. We have to give general anesthesia to the patient. General anesthesia, how will you give to the patient? It is given in 4 phases. General anesthesia is given in 4 phases. What are the 4 phases of general anesthesia? 4 phases of general anesthesia. First is pre-oxygenation. Second is induction. Third is maintenance. And the last is reversal phase. Okay? I and most of the anesthetists usually refer the 4 phases of general anesthesia is like flying an aeroplane. Okay? the first phase of the aeroplane. Okay, we know the four phases of general anesthesia. We just compare with the phases of aeroplane. The first phase of aeroplane will be what? It would be taxiing around the runway. Okay, aeroplane will be taxiing on the runway where there is fueling done. The aeroplane is refueled over here. Okay, fuel is added. The second phase of the aeroplane is the takeoff phase. You sit in the aeroplane, first is the taxiing phase. The second phase, takeoff phase of the aeroplane. Okay? The third phase of the aeroplane after takeoff, it will have to maintain itself in the mid-air. The third phase is the maintenance phase of aeroplane. And the last phase is called as landing phase. Okay? These four phases can be compared with general anesthesia. We usually anesthetists say giving general anesthesia is like flying an aeroplane where we have four phases. First, pre-oxygenation. Second is the takeoff phase. Third is the maintenance phase. Last is the landing phase of the aeroplane. Okay? Landing phase of the aeroplane. Now guys, we will compare. Why are we telling these phases and why are we comparing with the aeroplane? The first phase is called as pre-oxygenation. In pre-oxygenation, what should be your aim? Come on guys. Why pre-oxygenation is compared with the refueling phase? Right? Remember, when an aeroplane is taxiing on the runway, it is refueled by fuel. In general anesthesia, the first phase is pre-oxygenation. It's like refueling the humans. But instead of fuel, we are giving what? Oxygen to the patient. First phase is pre-oxygenation. In pre-oxygenation, what we need to remember, we need to pre-oxygenate the patient. We need to pre-oxygenate the patient for 3 to 5 minutes with 100% of oxygen, either by bag mask or either by normal oxygen mask. Either by bag mask or either by normal oxygen mask. Okay, that is the pre-oxygenation. Coming to the second phase of the aeroplane, takeoff phase. The second phase of general anesthesia is called as induction. Similar. What should be your aim in the induction phase of general anesthesia? In the induction phase, there should be 3 aims. What are the aims in the induction phase? The first aim in the induction phase should be, I should make the patient unconscious. I should make the patient unconscious. Basically, general anesthesia is making the patient unconscious. The second aim in the induction phase should be, I should make the muscles relax. And what should be your third aim? I should intubate the patient. Intubate the patient. That is the induction phase. Once the induction phase is done, once you have intubated, you go into the maintenance phase. Maintenance phase, like now flight has started, now it has to maintain itself. Anesthesia has started. The third phase is maintenance phase of general anesthesia. In the maintenance phase of general anesthesia, again there are 3 aims. What aims are? Come on, what should be aim in maintenance phase? It is not that difficult, guys. In the maintenance phase of general anesthesia, what are your 3 aims? The 3 aims, first aim is what? Same like induction phase. Here what we need to do? First aim should be maintain the patient unconscious. Basically, the 3 aims of induction are seen over here. But instead of make, you will write maintain. In the maintenance phase, maintain the patient unconscious. Then maintain muscle relaxation And last aim is maintain the ventilation. Maintain the ventilation. Once the maintenance phase is done, everything is done. Now you are happy, surgery is done. Now the last phase, then again, now the flight is totally done. The last phase is the landing phase or the reversal phase of general anesthesia. What should be your aim in the reversal phase of general anesthesia, guys? What should be your aim, guys? Your aim should be, come on, surgery is done. The aim should be what? Now make the patient conscious. Make the patient conscious. Second aim should be make the muscles contract. And the last aim should be, now don't tell me, sir, I will ventilate. Why ventilating? If he is conscious and all, he will breathe by himself. Is there any role of the ET tube? No. So the third aim is extubate the patient, remove the endotracheal tube. Okay. So the first phase we have discussed pre-oxygenation. Second phase is the induction phase. Okay. These are the 4 phases, guys. After pre-oxygenation, the induction phase. In the induction phase, now we will elaborate these 3 phases. In the induction phase, the first aim was make the patient unconscious. How will you make the patient unconscious? How will you make the patient unconscious? You make the patient unconscious by either IV induction agents that is used normally in 99%. It's not 90, guys. 99% of patients we use IV induction. Or in children, you can go for inhalational induction. In children, you can go for inhalational induction. Okay? And that too, one inhalational agent is commonly used in children for induction, that is sevoflurane. Why only sevo? There are many inhalational agents, halothane and all. Why sevo? Why? Because sevo is sweet odor. Sevo is sweet odor. Okay? So anyways, guys. So why do you use an inhalational induction in children? Why? Because children create a nuisance. They do not allow you to put an IV cannula. If you are not able to put an IV cannula, how will you give IV induction agent? It's not possible. So what you do? You go for a inhalational induction in children. Normally, you make the patient unconscious 99% by IV, but in children, in inhalation. Second aim is make the muscles relax. How will you make the muscles relax? Will you give a short-acting muscle relaxant or will you give a long-acting muscle relaxant? Which muscle relaxant will you give over here? Long-acting or short-acting in the induction phase? We are talking about the induction phase. Which muscle relaxant will you give? Now, guys, remember, the patient is posted for surgery. And any surgery, it will last for at least, it might last for like half an hour or 40 minutes if the surgery is fast. Or if it is a major surgery, it might take 7 to 8 hours. Which muscle relaxant should be given? Short-acting or long-acting? Come on, guys. That's the question to you. Right? Now, I know most of you are saying that, sir, surgery duration is 40 minutes. At least give a muscle relaxant that can act for 40 minutes. Yeah, they can go for a long-acting. Yes or no? Right? Guys, imagine if we go for a long-acting muscle relaxant. If we give long-acting, then what will happen? If I give a long-acting muscle relaxant. So basically, imagine a patient is posted for some surgery under general anesthesia. Again, the first phase of general anesthesia, I give him pre-oxygenation. Second phase is induction. In the induction phase, my 3 aims are what? Make the patient unconscious. How? By giving IV induction. Second is make muscles relax. Why making the muscle relax? As you guys are thinking about long-acting, I gave long-acting muscle relaxing to the patient. Now the third aim is what? Intubation. Intubation. Now guys, as I go for intubation, I put the endotracheal tube, I am trying to lift the tongue, but I am not able to see the vocal cords. If I am not able to see the vocal cords, how will I put an AT tube? I am not able to put the AT tube. If I am not able to put the endotracheal tube, slowly what I see on the monitor, the patient's saturation begins to fall. It has become 70%. Within no time, it became 50%. What should I do? I will remove the laryngoscope, ET tube, everything, and I'll try for a bag mask. But my bag mask ventilation is also not working for a long time. As I was overconfident that I will intubate, what mistake I did? I gave a long acting. Remember guys, always before intubation, always you have to go for a short acting muscle relaxant. Why? Because if at all you fail in intubation, at least by bag mask ventilation, but your bag mask ventilation works for 8 to 10 minutes and patient will regain his consciousness, he won't die. Patient won't die. When you go for what? When you go for what guys? When you go for a short acting muscle relaxant. Whereas long acting muscle relaxant means it will be mandatory for you that you have to intubate. Okay? So guys, remember, always, you're not thinking for the duration of surgery. You are thinking about what? You are thinking about the intubation. So always, before intubation, you give a short acting muscle relaxant. And after intubation, you can go for a long acting. So remember guys, in the induction phase, you make the muscle relax by giving what muscle relaxant? By giving a short acting muscle relaxant. Short acting muscle relaxant. Most commonly used over here is Scoline. Scoline, okay? Next, third aim is intubate the patient. Once the induction phase is done, the third phase of general anesthesia is what? Maintenance. Come on guys, in the maintenance phase, I told you what is the first aim. In induction, you have made the patient unconscious. Here, just you have to maintain him unconscious. How will you maintain the patient unconscious? Now, don't tell me, sir, I will give the IV induction agent every 10 minutes. Your IV induction agent will make the patient conscious for 10 minutes. Will you repeat the doses and give? No. For maintaining the patient unconscious, we use inhalational agent. That's why in general anesthesia we use combination of all these things, IV, inhalational and all, okay? Inhalational agents are used to maintain the patient unconscious. Second aim in general anesthesia, second aim in maintenance phases, second aim is maintain the muscle relaxation. How will you maintain muscle relaxation? Will you go for a short acting or long acting? Obviously, you go for a long acting muscle relaxant. Long acting muscle relaxant, right? Because patient has been intubated. Give a longer duration muscle relaxant. The third aim is maintain the ventilation. Okay. Next, what is the last phase of general anesthesia? Reversal phase. Surgery is done. Anesthetist is happy. Surgeon is happy. Surgeon is saying, now please bring back the patient to normal consciousness. So first aim in the reversal phase, in the landing phase, is what? Make the patient conscious. How guys? How will you make the patient conscious? How will you maintain the patient unconscious? Inhalational agent. Over here, just stop the inhalational agent. Patient will become conscious. He will become conscious, but he is not able to move. Why? Because you have paralyzed the patient with the help of muscle relaxant. So what should be the second aim after making the patient conscious? Make the muscles contract. How will you make the muscles contract? You have to give a reversal agent against muscle relaxant. You have to give a reversal agent against muscle relaxant. Okay? What is the reversal agent used against muscle relaxant? The reversal agents used against the muscle relaxants are neostigmine. Commonly used is neostigmine. Apart from neostigmine, there is a newer agent, reversal agent called as Sugamadex, which is commonly used for the muscle relaxants called as rocuronium, vecuronium, pancurone. Okay. Next, neostigmine, Sugamadex is there. Next, pyridostigmine is used as a reversal agent. Edrophonium is used as a reversal agent. Apart from that, L-cysteine can be used. L-cysteine can be used as a reversal agent, but L-cysteine is commonly used for a muscle relaxant called as gantancurium. Guys, just remember the most commonly used is neostigmine and Sugamadex. These are the commonly used reversal agent. But whenever you are giving reversal agent against muscle relaxant, don't give this reversal agent plain. Example, I'll give you an example. If you give neostigmine in the reversal phase, plain neostigmine in the reversal phase, it will cause muscle contraction. At the same time, it will cause bradycardia, right? Or it will also cause increase in salivation. So what we do, guys, we mix neostigmine with either glycopyrrolate, which is an anticholinergic, or atropine. Any one of this, but we use in combination. Neostigmine with glycopyrrolate or neostigmine with atropine. Why? Because that will encounter the side effects of neostigmine. That will increase the heart rate and decrease the salivation. Okay? That's regarding what? That's regarding the reversal phase. Now, guys, in the reversal phase, one more thing that we need to remember. After reversing the patient from anesthesia, after giving the muscle, after giving this neostigmine and all, how will you come to know that your patient is adequately reversed? There are some signs of adequate reversal. The signs of adequate reversal are, the best sign is what, guys? You tell the patient to please lift your head. If he is obeying your command, if he is lifting his hand, lifting his head is considered as a best sign or an adequate sign for reversal. For more than 5 seconds, that is a sign of adequate reversal. Or if you check a Trainor-4 ratio that comes as more than 0.9. Remember, guys? Signs of adequate reversal. The best sign is sustained head lift for more than 5 seconds. Next, moving all limbs. Next, obeying to commands. Next, Trainor-4 ratio more than 0.9. I know most of you don't know what is Trainor-4 ratio. Some of you might be aware, but don't worry, guys. As and as we are progressing, I will teach you the concept of Trainor-4 also, okay? So these are what, guys? These are the signs of adequate reversal, okay? Now, guys, remember, the best sign for adequate reversal is head lift. It is head lift. But what is the overall best? Overall best is Trainor-4. Is Trainor-4. Trainor-4 ratio more than 0.9. That's the overall best sign for adequate reversal, right? So that's regarding what, guys? That's regarding the reversal phase of general anesthesia. Hope these 4 phases of general anesthesia are clear to you. Okay. In the reversal phase, we forgot to tell you about extubation. Once the patient is adequately reversed, you extubate the patient. So that's regarding what, guys? The reversal phase of general anesthesia. So, guys, next starting with. So, guys, now I told you one case. If you guys remember, I told you one small case. In that case, I have mentioned that A person was riding a bike. While discussing the PAC, I told you, person was riding a bike. He met with a road traffic accident. He was riding a bike. He was coming from a wedding. Okay? He met with a road traffic accident and is being diagnosed with IC bleed. And the surgeon is calling you for giving anesthesia. Which anesthesia will you give? First of all, is the patient full stomach or not? In any emergency scenarios, whether you know the patient's fasting status or not, you have to consider them as full stomach. In any patient who's full stomach, how will you give general anesthesia? How is general anesthesia given to a full stomach patient? Again, so I had asked you in the PAC. Now we will just discuss a few points regarding it. Remember, guys, if the patient is full stomach and you have to give general anesthesia, imagine we are giving general anesthesia to this patient. So once I enter the operation theater, right, I have to give general anesthesia. It will be given in 4 phases. What 4 phases? You know it. Pre-oxygenation, okay? Induction. Next, maintenance. And last, reversal. So, first, we need to understand, if at all I take the responsibility to give general anesthesia to a full stomach patient, I usually go for a procedure which is called as RSI. Now, sir, what is RSI? RSI is nothing but rapid sequence induction. Now, what is rapid sequence induction? Rapid sequence induction is nothing but general anesthesia given to full stomach patient. General anesthesia given to full stomach patient. That is called as rapid sequence induction. Now, what is rapid sequence induction different from the normal general anesthesia? No, sir, but some modifications. What modifications? In rapid sequence induction or general anesthesia, all these phases are seen. Same phases of general anesthesia are seen. Okay? Now, guys, in normal general anesthesia, you give pre-oxygenation for 3 to 5 minutes with either normal mask or bag mask. In rapid sequence induction, how will you give pre-oxygenation to the patient? How? Will you go for a normal mask or a bag mask? Guys, that's a question. Normal mask or bag mask? If you go for a normal mask, the patient will just inhale. If you go for a bag mask, you keep a mask over here. There will be a bag where we are forcefully pushing the air into the patient's mouth. Which one will you give? You always give pre-oxygenation with a normal mask. In the case of RSI, normal mask. Bag mask ventilation is avoided. Bag mask ventilation is avoided. Why bag mask ventilation is avoided, guys? Okay, normal mask you are giving. Bag mask ventilation is avoided. Why it is avoided? If you go for a bag mask ventilation, due to forcefully pushing the air into the esophagus, into the trachea, some of the air might go into the esophagus, and if the patient is full stomach, the patient will regurgitate and aspirate. So bag mask ventilation causes aspiration, hence bag mask is avoided. Bag mask ventilation is avoided. Okay? Now, right? So general anesthesia given to a full stomach patient is called as RSI, which is called as rapid sequence induction. In rapid sequence induction, what we did, first we give pre-oxygenation with normal mask. What is avoided? BMV is avoided. Very, very important. BMV is bag mask ventilation is avoided. Then we go into the induction phase. In the induction phase, what do you do? Again, the aim is make the patient unconscious, make the muscles relax, and intubate. How will you make the patient unconscious? By giving IV induction. Once the patient is unconscious, you have to give muscle relaxant. Yes or no? So, in rapid sequence induction, in the induction phase, First is we make the patient unconscious. Same like general anesthesia. Second, make muscle relax. Third, intubate. But the small change over here is what? In this case, once the patient is made unconscious, what we need to do? We need to remember, when he's conscious, he won't aspirate. Once the patient is full stomach and you make him unconscious, he will aspirate. The moment you make him unconscious, tell your assistant to apply pressure on the cricoid cartilage. That will press the cricoid cartilage. So he will press the cricoid cartilage so hard that the esophagus gets closed, right? That maneuver is called as Selleck's maneuver. That maneuver is called as what, guys? Selleck's maneuver. For better understanding, just look over here, guys. Immediately after induction, your assistant will apply pressure. Just here, look over here. He'll apply pressure. Where is he applying pressure? He is applying pressure on the cricoid cartilage that is blocking the esophagus. This is called as Selleck's maneuver. Selleck's maneuver. My question to you is, again, there are two questions over here. One is, when are you applying Selleck's maneuver? You apply after induction. The second question pertaining to Selleck's maneuver is, when do you remove it? When is Selleck's maneuver removed? So guys, basically, you have made the patient unconscious. Your assistant had applied this Selleck's maneuver. Now, after application of Selleck's maneuver, muscle relaxant is given. After muscle relaxant, you intubate. When do you remove this? When do you tell your assistant to remove the pressure? The Selleck's maneuver is removed after intubation. After intubation, right? But this is the half answer. For full answer, just look over here. A small question to you. Imagine this is the trachea of the patient. Okay? This is the trachea of the patient. And here is the endotracheal tube. This is patient A. This is patient B. Again, this is the trachea. Right? Next, here is the endotracheal tube. Now, you might see a difference, guys. Over here, the endotracheal tube that I have used is called as uncuffed tube. Uncuffed tube. In this picture, I have used a cuffed tube. You guys tell me, which tube should I use in a patient who's full stomach? That is nowadays commonly used for every cases. What is a tube? Cuffed endotracheal tube. The cuffed endotracheal tube. If you are using a cuffed endotracheal tube, why do you use it over here? Why? Because this cuff over here encircles the whole lumen of the trachea, and even though if the patient might regurgitate some contents, can the regurgitant go into the lungs? No. This cuff tube prevents aspiration. So your complete answer, when are you removing Selleck's maneuver? After intubation and inflation of the cuff. After intubation and after inflation of the cuff, then you remove the Selleck's maneuver. Okay? These are the steps of rapid sequence induction. In rapid sequence induction, it's same like general anesthesia, but here we pre-oxygenate the patient with normal mask. Second, immediately after IV induction, we give what, guys? We give Selleck's maneuver. We give Selleck's maneuver or assistant? Assistant will give Selleck's maneuver. When you are applying and when you are removing is important, okay? Next, that's regarding what? That's regarding the Selleck's maneuver. So in what patients we have to go for Selleck's maneuver? In which patient we have to go for Selleck's maneuver? in the patients who are at risk of aspiration. Salix maneuver is done, or RSI, rapid sequence induction, is done in patients at risk of aspiration. Who are the patients who are at risk of aspiration? Obese patient, pregnancy, SITs, GERD, hiatus hernia. These are all patients who are at risk of aspiration. Okay. So guys, this is regarding the Salix maneuver. Right. Now guys, starting with the IV induction agents. Starting with what guys? IV induction agents. IV induction agents. We are dealing with the induction phase. Pre-oxygenation we have seen. We are now starting with the induction phase. In the induction phase, the first aim of your induction phase is to make the patient unconscious. How will you make the patient unconscious? You make the patient unconscious by IV induction agents in 99%, and in children you use inhalation. So first we are discussing about the IV induction. There are two types of IV induction agents. First of all, you need to understand IV induction agents are also called as IV sedatives or IV hypnotic agents. There are two categories of IV induction agents. One category of IV induction agent is called as opioid category. Other category is called as non-opioid category. In non-opioid category, further you are having the barbiturates and the non-barbiturates. The barbiturates and non-barbiturates. Again, but commonly what we are using for giving general anesthesia, we use the non-opioid category, the barbiturates and the non-barbiturates. Opioids are used to make the patient unconscious. Sorry, start this. Right. Opioids are used as an induction agent, IV induction agent in selected patients only. What selected patients? If the patient is having severely reduced ejection fraction, there you can go for opioid induction. But normally, in 90% of the cases, we go for non-opioid induction. So first we will discuss the non-opioid. Okay? Non-opioid induction. So I told you in non-opioid that there is barbiturate and non-barbiturate. In the barbiturate, again there are two drugs. One is thiopentone, that is sodium thiopentone. Other is methohexital. Right? Whereas in non-barbiturates, we are having propofol, ketamine, etomidate, and benzodiazepine. These are non-barbiturate type of IV induction. Okay? In benzodiazepines, first we will discuss the rare, because next you have to concentrate much on the most commonly used. Okay? So benzodiazepine is rarely used. A few points of benzodiazepines, guys. A few points of benzodiazepine that we need to remember is, in benzodiazepine, if you want to induce a patient with benzodiazepines, you are having example as you can use midazolam, you can use diazepam, many drugs are there. Or you can also use remidazolam. Right? Remidazolam is more faster as well as more potent than midazolam. Remidazolam is more faster and it is more potent than midazolam. Right? Benzodiazepines or midazolam are usually used for IV induction if the patient is in sepsis-like condition. In sepsis-like condition, they are used for induction purpose. Okay? Induction purpose. If at all the patient lands up into, there is just a miscellaneous point of benzodiazepine. If the patient lands up into benzodiazepine poisoning, if you have given a very higher dose of benzodiazepine, the antidote that is used for benzodiazepine poisoning reversal is, the antidote is flumazenil. Flumazenil. Okay? So that's regarding what? Benzodiazepine. So anyways, guys, we are still dealing with the IV induction agents, right? Now, concentrate much on the commonly used IV induction agents. The commonly used IV induction agents are what? It is propofol. It is thiopentone, sodium thiopentone. It is etomidate. Right? And one more drug is there called as ketamine. Ketamine. These four are the commonly used IV induction agents. The first three, why I have written over there as third, and the fourth, why I have taken a gap. Why? Because propofol, thiopentone, and etomidate causes induction or induces sleep by acting on GABA receptors. GABA receptors. Whereas our ketamine causes induction or makes the patient unconscious by acting on NMDA receptors. NMDA receptors. That's regarding the ketamine. Okay? Right? So these were the IV induction agents, the most commonly used. Now we will discuss each of the IV induction or the IV sedative or the IV hypnotic agents. Okay? Guys, you have to concentrate on more when I am writing this QQ. Okay? Because this was previously asked, or this is the highly important topic. Next, guys, starting with the first IV induction agent, which is called as sodium thiopentone. Sodium thiopentone. Guys, whenever we are discussing a drug or IV induction agent, we have to discuss four things. The first thing that we need to discuss is the introduction and pharmacokinetics of the drug. Introduction and pharmacokinetics of the drug. The second thing that we need to discuss is about the effect of drug on various systems. Effect of drug on various systems. Third that we need to discuss is contraindications. Contraindications of the drug. So first starting with sodium thiopentone. Sodium thiopentone is an IV induction agent. Now you have to have a good picture memory of thiopentone. This is the vial of sodium thiopentone. On your screen, this is the vial of sodium thiopentone. Create a picture memory in your mind. Sodium thiopentone is what color, guys? Sodium thiopentone is yellow amorphous powder. It's a yellow amorphous powder, right? And it is an ultra short acting barbiturate. It's an ultra short acting barbiturate. Ultra short acting barbiturate. Why it is an ultra short acting barbiturate? The reason why it is an ultra short acting barbiturate is it is having rapid redistribution. The reason is what, guys? It has rapid redistribution. All drugs are short acting only, but sodium thiopentone is ultra short acting. Why? Because it's having rapid redistribution. Sodium thiopentone was invented by Dr. John Lundy. Now you must be thinking, we have just now discussed John Lundy somewhere. John Lundy was the guy who gave the term balanced anesthesia and he discovered sodium thiopentone. Okay, right? Very important. Next is, what does we need to remember of sodium thiopentone? What is the pH of sodium thiopentone? The pH of sodium thiopentone is 10.4. How is the sodium thiopentone prepared? Sodium thiopentone is prepared as a 2.5% concentration or 5% concentration. And basically, how much of water you are adding depends on that only. The concentration might be 2.5% if you add much water. If you add less water, it will be 5% of sodium thiopentone and all. Okay. But guys, while preparing sodium thiopentone, you can use what? You can use, you take this powder and mix it with normal saline, DNS, okay, or any fluid except for Ringer's lactate. Sodium thiopentone should never be prepared with Ringer's lactate. Thio should never be prepared with Ringer's lactate. Why? Why? Because it can form crystals. It forms crystals. Hence, it is avoided with Ringer's lactate. So that's regarding what is? That's regarding the introduction of sodium thiopentone. Right? Introduction of sodium thiopentone. Now, what does we need to remember of the sodium thiopentone? After introduction, remember, we have to also remember pharmacokinetics. Pharmacokinetics of sodium thiopentone. In the pharmacokinetics, what we need to remember? The dose, the onset, the duration, and the elimination T-half. I used to remember DODE. D is the dose. Dose is 3 to 5 mg per kg body weight. O is onset. After giving sodium thiopentone, the patient becomes unconscious within 11 seconds. Hence, it is regarded as fastest acting IV induction agent. Fastest IV induction agent. Okay. Next, D stands for duration. For how much time the patient will be unconscious? All drugs, it will take 10 minutes only. 10 minutes. Okay. Last is elimination T-half. How much is the elimination T-half of sodium thiopentone? How much time will it take for half of sodium thiopentone to get eliminated? It will be 10.4 hours. As sodium thiopentone is having long elimination T-half, can it be given for daycare surgery? Yes or no? First, understand what is daycare surgery. First, you have to understand what is daycare surgery. Daycare surgery means surgery on the same day, discharge on the same day. Can you give sodium thiopentone in daycare surgery? The answer is absolutely no, sir. Why? The T-half is 10.4 hours. The patient should be in the hospital till the drug is being eliminated and all. Okay? So you can't give sodium thiopentone in daycare surgery. It can't be given. Which is the IV induction agent of choice for daycare surgery? The IV induction agent of choice for daycare surgery is propofol. Is what, guys? Propofol. Why propofol? It's having a short elimination T-half of less than 2 hours. Very important, guys. Very important. Okay? That's regarding the introduction and pharmacokinetics. Now, guys, coming to the next thing of sodium thiopentone, that is effects of sodium thiopentone on various system. Now guys, as we are discussing about the effects of sodium thiopentone on various systems, what systems we need to cover? We need to cover the central nervous system, the respiratory system, the cardiovascular system, the muscle, and last system is analgesia, any analgesic property. Analgesia. These are the 5 systems we need to cover regarding thiopentone. There have been many MCQs, or there are MCQs coming from this part of sodium thiopentone. What is the effect on CNS, CVS, and all. So I used to remember all these things in one line. How I used to remember a small thing regarding it. Whenever there is regarding the effects of sodium thiopentone on various systems, I used to remember that sodium thiopentone is best friend of CNS and enemy of other systems. Enemy of other systems. Right. Sodium thiopentone is the best friend of CNS and enemy of other systems. When I am going with this term, best friend of CNS, what does it mean? It will basically be beneficiary for the CNS, or it could be basically used as an IV induction agent of choice for CNS problems. Hence, it is a best friend. No. Okay. Enemy of other systems means what? Sodium thiopentone will be having contraindication toward these systemic diseases, or contraindication for the diseases of this system. Contraindicated in respiratory disease such as asthma, contraindicated in ischemic heart disease, not good for muscle, not an analgesic. Okay? So one line, thiopentone is the best friend of CNS, enemy of all other systems. Now when I am telling this, what is it doing to the CNS? Very, very important, guys. What does sodium thiopentone do to the CNS? Okay. So what's the effect of sodium thiopentone on the CNS? Effect on CNS, as I am telling, it is a good friend or best friend, guys? Best friend. Okay, a good friend will have one good quality. It is a best friend. Best friend has 3 to 4 good qualities. So sodium thiopentone is having 3 good qualities on the CNS. The first good quality is what? It decreases the intracranial pressure. The second good quality is what? Sodium thiopentone is having anti-epileptic property. Hence can be used in the management of status epilepticus or epileptic patients. Third good quality of sodium thiopentone on CNS is what? It can be used for narcoanalysis. All 3 are important. How is sodium thiopentone decreasing the ICP? Sodium thiopentone causes cerebral vasoconstriction, which decreases the ICP, and also it decreases the cerebral metabolic rate. Right? So, it causes cerebral vasoconstriction and also decreases the cerebral metabolic rate. As it is decreasing the ICP, sodium thiopentone is the IV induction agent of choice for head injury or neurosurgery. Head injury or what surgery? Neurosurgery. Okay? Next, sodium thiopentone can be used as an anti-epileptic. Okay? Sodium thiopentone is having anti-epileptic property, hence it can be used as an IV induction agent. IV induction agent in patients with epilepsy or status epilepticus. Status epilepticus. Third thing of sodium thiopentone is it can be used for narcoanalysis. Narcoanalysis meaning what? narco testing, the court orders for the narco test, where we give some drug to the patient. Patient goes into a subconscious state. You ask anything to the patient, 90% of the time we will tell the truth. But again, there is a margin of error in that. But we don't have to go for narco testing in detail. Just remember the drug commonly used in narco analysis is sodium thiopentone. So as it is having 3 good qualities on CNS, I have declared sodium thiopentone as a best friend of CNS. Now guys, coming to second symptom, respiratory. Come on. One line we have to remember once again. What was that line? Sodium thiopentone is the best friend of CNS, enemy of others. CNS is gone. Coming to the enemies. As it is an enemy, it will have contraindication to respiratory diseases. As it is an enemy of cardiovascular, contraindicated in cardiovascular disease. So guys, as it is an enemy of respiratory system, first of all, why it is an enemy, we have to learn it. Sodium thiopentone releases histamine. It releases histamine, leading to bronchospasm. Hence, can you give sodium thiopentone in a patient who is suffering with asthma? Due to this reason, it can't be given. So, sodium thiopentone is contraindicated in patients suffering with bronchial asthma. That's regarding the respiratory. Next is what, guys? Cardiovascular. Cardiovascular, anemia ya friend hai, it's an enemy. So it will be contraindicated for cardiovascular diseases. That could be shown. But why? That we need to remember. Sodium thiopentone, when you give to the patient, it will decrease the BP and it will increase the heart rate. Why it is decreasing the BP? Due to peripheral vasodilation, it is decreasing the BP, and due to vagolytic action of sodium thiopentone, the heart rate gets increased. Okay? So it causes hypo and tachycardia. Hypo plus tachycardia. So can you give sodium thiopentone to a patient who is in shock? What's your answer? In shock, sir, the BP is 80/50. If you give sodium thiopentone, BP becomes 50/20. Hence, it is contraindicated in shock. Can you give sodium thiopentone in ischemic heart disease? Yes or no? Ischemic heart disease patient cannot tolerate extreme changes in the BP and pulse rate. Extreme changes in BP and pulse rate. What is sodium thiopentone doing to the BP and pulse rate? It is causing hypo and tachy. This is very important, guys. Sodium thiopentone causes hypo and tachy. That's the differentiating feature of sodium thiopentone with propofol. Okay? So remember, both sodium thiopentone and propofol both are causing hypotension. But sodium thiopentone with hypo, it will cause tachy. Propofol causes brady. Thiopentone starts with T. Tachycardia starts with T, we can remember. Okay? So, thiopentone causes hypo and tachycardia. So, can you give sodium thiopentone in ischemic heart disease? No, sir. It is contraindicated in ischemic heart disease. So, cardiovascular system is done. What is the next system? Muscle. What is the effect of sodium thiopentone on muscle, sir? Sir, it is an enemy, but there is still no effect. Neither a good effect, neither a bad effect. There is no effect on muscle. Last system is analgesia. Analgesic system. Enemy hai ya friend hai? It's an enemy. So will it produce analgesia? No. Instead, sodium thiopentone produces pain during injection. Produces pain during injection. While you are injecting sodium thiopentone, patient will have pain, right? Apart from that, what else we need to remember is it an analgesic? There is no analgesia. It won't produce any analgesia. No analgesia, right? One more extra point of sodium thiopentone in context of thyroid gland is what? Sodium thiopentone is having a unique anti-thyroid property. Meaning what? If the patient is suffering with hyperthyroidism, if patient is hyperthyroid, the best IV induction that could be given is what? Best IV induction is sodium thiopentone. Why? Because it is having anti-thyroid property. Anti-thyroid property. So these are the points of sodium thiopentone that we need to remember in context of the effects. Remember the one line? Surely, guys. Best friend of CNS, enemy of others. Best friend of CNS means IV induction agent of choice for CNS problems. Whereas the enemy of others means contraindication for the diseases of other systems. Okay? Next, guys. The last thing about the drug that we need to discuss is about the contraindication. In which condition sodium thiopentone is contraindicated? Guys, sodium thiopentone is contraindicated in acute intermittent porphyria. There is a disease called as acute intermittent porphyria where you never give sodium thiopentone. It can be safely given in cutaneous porphyria tarda. It can be safely given in cutaneous porphyria tarda. But in acute intermittent porphyria, sodium thiopentone is highly contraindicated. Okay? What is the IV induction agent that is given in porphyria? That IV induction agent starts with P and porphyria also starts with P. So the IV induction agent of choice for porphyria is propofol. So one contraindication, porphyria we have discussed. But it can be safely given in, this is very important, cutaneous porphyria tarda. Next is, what's the next contraindication? Remember contraindications, if anyone is asking you, you can easily tell regarding the systems. Systems say, contraindication. Any say there will be contraindication. So, sir, sodium thiopentone is contraindicated in respiratory disease such as bronchial asthma. Sodium thiopentone is contraindicated in ischemic heart disease as well as shock. That we need to remember. Okay. So, contraindications we have discussed, right? 2-3 contraindications we have already discussed. Hypotension and shock made is contraindicated. In shock-like conditions, ketamine is the IV induction agent of choice. Okay, that we will discuss later. The last contraindication of sodium thiopentone is you never give sodium thiopentone if you are placing an IV cannula in the cubital fossa. The question should be, why, sir? Why is it contraindicated when you place a cannula in the cubital fossa? Guys, remember, whenever you are placing a cannula in the cubital fossa, there is a much chance that your cannula might migrate into the artery. Why? Because artery is nearby the vein over there, right? If at all your cannula has migrated into the artery and you were not aware and you gave sodium thiopentone inside the artery by mistake, what will happen? Intraarterial injection of sodium thiopentone, what will it do, guys? It will form crystals inside the blood that can cause severe vasoconstriction. If not treated within time or within no time, the patient might develop gangrene of the upper lip, right? So injection of sodium thiopentone is avoided in the cubital fossa due to the risk of displacement of cannula inside the artery, right? So now guys, if at all, imagine you have given sodium thiopentone intraarterial, what will you do now? What will you do now? Will you keep the cannula or will you remove the cannula? Keep or remove, guys? Come on. You have to keep the cannula. Don't remove the cannula. If you remove the cannula, it will be difficult for you to identify what artery it has gone into. Okay? Keep the cannula. The main reason of keeping the cannula is you can give the management of this condition through that cannula. The patient develops vasoconstriction. Patient develops thrombosis due to the sodium thiopentone. What you can give? By keeping the cannula, you can give papaverine, you can give vasodilators, you can give heparin, right? Antithrombus solution called as heparin, right? So keep the cannula the same side, give vasodilators, give papaverine, give heparin, right? Give lignocaine. Why are you giving lignocaine? It's a very painful condition. It's a painful condition. To relieve the pain, you are giving lignocaine. If nothing works, always think that the patient might land up into gangrene. If nothing works, immediately what you should do, guys? Immediately you should go for a block called as stellate ganglion block, or you can also go for brachial plexus block. Brachial plexus. So we are going for any one of them. Either you go for stellate ganglion or either brachial plexus block. With either of the block, the blood vessels get dilated and the symptoms will subside. So this is regarding what? This is regarding sodium thiopentone intra-arterial injection if you give. Okay. So these were the contraindications of sodium thiopentone. These were the contraindications of sodium thiopentone. So guys, starting with the next IV induction agent, which is called as propofol. Propofol. The other name for propofol is also called as 2,6-diisopropylphenol. Now regarding this propofol, what we need to remember is propofol is available as a milky white solution. Propofol is, we have to discuss the introduction, guys. Introduction of propofol. So propofol is a milky white solution. Apart from propofol, ethambutol is also a milky white solution that is used for induction. Okay. So propofol, why it is a milky white solution? Why? Because it is made up of egg. It is made up of eggs. E stands for it is made up of egg lecithin. G stands for it is made up of glycerol. And S is soybean. Right? Egg lecithin. Egg lecithin is usually it acts as an emulsifying agent. Egg lecithin acts as emulsifying agent. Recently this was asked. Okay. So the rule is whenever you use propofol or whenever you open the propofol vial, it should be used or it should be consumed within 6 hours, or within 6 hours you have to use it. Why? Because bacterial contamination can easily happen with propofol. Nowadays, most of the anesthetists, what they do, guys, they open the propofol vial, they take some 5 ml or 8 ml. Then again for the next case also they keep the same vial. This shouldn't be used, guys. So once you open the vial, use it within 6 hours. Otherwise, bacterial contamination can easily happen. Okay. Now, guys, in this propofol, what we need to remember is there is a drug which is called as fospropofol. There is a prodrug. Nowadays, there is a prodrug that is being prepared from propofol called as fospropofol. It is a prodrug that contains EDTA, hence it is a bacteriostatic drug. Bacteriostatic, right? So again, that was the introduction of propofol. One more point in the introduction, what we need to remember, Propofol makes the patient unconscious by acting on what? By acting on GABA receptors. All the IV induction agents act on GABA except ketamine that acts on the NMDA. Now, next thing about propofol is what is the effect of propofol on various systems? So we have discussed about the propofol. We have discussed the introduction. Now we'll discuss the effects of propofol on various systems. Now guys, what systems we need to cover? We already know. CNS, CVS are respiratory, muscle and analgesia. So guys, regarding propofol, I used to remember this one line. Propofol is just a friend of CNS and enemy of other systems. Basically, propofol and thiopentone both are very much similar. Thiopentone was the best friend of CNS, enemy of others. Propofol is a just a friend of CNS. What is meant by just friend? Only one quality. Thiopentone, why it is regarded as the best friend? Why? Because it is having three qualities. What is that one quality of propofol on CNS? I told you it is a just a friend of CNS. So what will it do? Propofol will also decrease the ICP. It will also cause cerebral vasoconstriction. Okay? Decreases the intracranial pressure, but it is not having any other properties same like thiopentone. Hence, propofol is regarded as the second best IV induction agent for head injury and neurosurgery. Head injury and neurosurgery. Which one is the best, guys? The best is sodium thiopentone. The best is sodium thiopentone. Next, respiratory system. Friend hai ya enemy hai? It's an enemy. So propofol, even though it's an enemy, it's not that kind of worst kind of enemy. Remember, propofol, what does it do to the respiratory system? Propofol blunts the protective airway reflexes. Protective airway reflexes. Epiglottic reflexes blunted by propofol. Okay? So it blunts the protective airway reflexes, and it is also having, it also has mild bronchodilatory effect. It has mild bronchodilatory effect. It doesn't mean that it is a potent bronchodilator. Potent bronchodilator is only ketamine. Okay? So propofol blunts the protective airway reflexes. Coming to the next system, cardiovascular. What will propofol do to the cardiovascular system? Propofol will cause hypotension and it causes bradycardia. It causes hypotension and bradycardia. How does it cause hypotension? We know the reason. Peripheral vasodilation. It will do. It will cause hypotension by peripheral vasodilation. How will it cause bradycardia, guys? Bradycardia of propofol is seen as it will blunt the carotid body reflexes. It blunts the carotid body reflexes. Okay? Hence, can you give propofol in a patient who is suffering with or in a patient who is in shock? Yes or no? The answer is No. Why? Because it causes hypo and bradycardia. This feature is very important. Thiopentone was causing hypo and tachy. Next, can you give propofol in ischemic heart disease? The answer is no. Why? Because these patients can't tolerate hypotension. They can't tolerate hypotension. This is regarding the cardiovascular system. Coming to the next system of propofol, that is what is CNS we have discussed, respiratory we have discussed, cardiovascular we have discussed. Next system is what? Muscle. Same like thiopentone. I usually refer thiopentone and propofol are my brother and sister. Where thio is the brother, propofol is the sister. Okay? So it has no effect on muscle. How about the analgesic property? There is no analgesia. It will also cause pain during injection. It will also cause pain during injection. This pain while injecting propofol can be reduced by adding lignocaine to the propofol. To reduce the pain of injection of propofol, we add lignocaine to it. We add lignocaine with propofol. Okay, that's regarding what, guys? That's regarding the effects on various systems. Now, after the effect, the third aspect of the drug that we need to cover is about the contraindication. Contraindication. Come on, guys. Propofol is contraindicated in. Contraindication means you have to go directly on the effects. Two contraindications will come. What two contraindications? Respiratory may, no, it's having mild bronchodilatory effect, it can be given. Next, it's an enemy of cardiovascular. So it is contraindicated in ischemic heart disease and it is contraindicated in shock. Apart from that, you can't give propofol as a continuous infusion. Okay, guys? You can't give propofol as a continuous infusion. Continuous infusion. What is this continuous infusion, guys? What is this continuous infusion I'm talking about? Which patient requires a continuous infusion of propofol? Patient in the operation theater or patient in the ICU? A patient who is in ICU, who's on ventilator, will you want him to be conscious so that he fights with the ventilator and all? No. You want the patient to be sedated on ventilator, right? So, in ICU, if the patient is on ventilator, you have to go for long-term sedation. Can you give propofol? Yes or no? If you give propofol, if propofol is used as a long-term sedation for more than 48 hours or more, the dose of propofol more than 4 mg per kg, then the patient will land up into what? Patient might land up into a thing called as propofol infusion syndrome, which is characterized by what? Which is characterized by skeletal myopathy, cardiomyopathy, rhabdomyolysis can happen with this propofol. Metabolic acidosis can happen with this propofol. There is a triad, guys. Metabolic acidosis, cardiomyopathy, and skeletal myopathy, right? Metabolic acidosis, cardiomyopathy, skeletal myopathy. This is the triad commonly seen in children. So never give propofol as a long-term infusion. Propofol should never be given. Instead of propofol, can you give ketamine as a long-term infusion in ICU? No, sir. Can you give etominet? No. In ICU, if the patient requires sedation, you go for these drugs called as midazolam, fentanyl, and dexmedetomidine. Midazolam, fentanyl, and dexmedetomidine. These are the drugs used for long-term ICU sedation. Whenever I go into the ICU and I see a patient is on ventilator and a sedation is not given, I usually tell the nurse to prepare fentamidaz infusion. Fentamidase infusion. What is this fentamidase infusion? Fenta is fentanyl, midase is midazolam. Fentamidase infusion we give to the patient for long-term ICU sedation, not propofol. Okay. So propofol, if you are given for more than 48 hours, propofol infusion syndrome can happen. That is characterized by what are the clinical features of propofol infusion syndrome? Patient will have refractory bradycardia. The clinical features of propofol infusion syndrome is patient will have refractory bradycardia. Patient will also have green color urine. Green color urine. Why? Because the patient had rhabdomyolysis. Hence, he's having a green color urine. Okay. So, propofol should not be given as long-term infusion. These were what, guys? These were the contraindications of propofol. Before going to the important slide of propofol, guys, we also have to discuss something about the pharmacokinetics that we have missed over here. Pharmacokinetics of propofol. I forgot to tell you about the pharmacokinetics of propofol. In pharmacokinetics, again, we go with the D, O, D, E. D of propofol is dose. O is onset. The dose of propofol required to make the patient unconscious is 1.5 to 2 mg per kg body weight. O is onset. After giving this dose, within 30 to 45 seconds, the patient becomes unconscious. 30 seconds, the patient, 30 to 45 seconds, the patient is unconscious. Duration, it is 10 minutes. And E is elimination T-half. Elimination T-half of propofol is 2 hours or less than 2 hours. As it is having a short elimination T-half, as it has short elimination T-half, it is regarded as IV induction agent of choice for what surgery? IV induction agent of choice for daycare surgery. Daycare surgery. Very, very. Okay. Now, guys, we have to discuss a few points where propofol is used as an IV induction agent of choice. Propofol is used as an IV induction agent of choice in many conditions. What many conditions are we referring to? What many conditions are we referring to? Propofol is an IV induction agent of choice for daycare surgery. Propofol is an IV induction agent of choice for LMA insertion. What is meant by LMA insertion, guys? Daycare surgery. Second, propofol is used as an IV induction agent of choice for LMA insertion. What is meant by LMA? LMA is laryngeal mask airway. Laryngeal mask airway. If you are not able to intubate the patient, at least secure the airway by a temporary airway device. It's a temporary airway device called as laryngeal mask airway. Okay? In laryngeal mask airway insertion, the IV induction agent that would be required for the insertion is propofol. Okay? So we have discussed two conditions. Daycare surgery, it is an IV induction, LMA. Third, propofol is an IV induction agent of choice for porphyria. Fourth, propofol is having anti-emetic and anti-pruritic property. It is the only IV induction agent that is having anti-emetic or anti-pruritic. This slide is damn important. So it is the only IV induction agent that has anti-emetic or anti-pruritic property. Next, propofol can be used as a component of TIVA. Now guys, what is this TIVA? What is this TIVA? TIVA का मतलब क्या है? Total intravenous anesthesia. Meaning what? What is total intravenous anesthesia? General anesthesia given to a patient without giving inhalational agent is called as TIVA. General anesthesia given to a patient without using any inhalational agent is called as TIVA. Right? So propofol can be used as a component of TIVA. In TIVA, normally TIVA is used for malignant hyperthermia patient or patients suffering with cardiovascular disorders. Okay? Hence, propofol is also regarded as IV induction agent of choice for malignant hyperthermia. IV induction agent of choice for malignant hyperthermia. Basically, it's a favorite IV induction agent. Many conditions it is used as an IV induction agent of choice. Okay. So it's a component of TIVA. TIVA is total intravenous anesthesia, which can be used in malignant hyperthermia or cardiovascular disorders. Okay. In TIVA, we use a combination. In TIVA, what combination we use? We use propofol plus remifentanil. That is the best combination of TIVA. Okay? There are other drugs, midazolam, other drugs can be used, but these are the drugs. Okay? So propofol remifentanil is the best combination of TIVA. This 6 conditions you have to remember. You also have to remember that for liver disorder also it is an IV induction. Propofol is used as an IV induction agent of choice for any liver disorder. It's a IV induction agent of choice for liver disorder. So you have to remember this, guys. Always remember propofol is the favorite IV induction agent for the anesthetist. Daycare surgery, LMA insertion, TIVA, antiemetic property, right? And malignant hyperthermia, liver surgeries, all these conditions propofol can be used safely. These points are very, very important regarding propofol, right? Now guys, coming to the next IV induction agent, which is called as ketamine. Ketamine. Come on guys, we are starting with a new IV induction agent. So we have to discuss the introduction. We have to discuss the pharmacokinetics. We have to discuss the effects. Okay? Introduction, pharmacokinetics. We have to discuss the effects and last contraindication. Ketamine. Ketamine is usually called, or it is very close to being called as a complete anesthetic agent. The reason being, we'll discuss that reason later. Okay? Introduction of ketamine. We are discussing about the introduction of ketamine. In the introduction of ketamine, we need to remember ketamine is a phencyclidine derivative. It's a phencyclidine derivative. And it acts on what receptor? It is an NMDA receptor blocker. It acts on the NMDA receptor. It's an NMDA receptor block. It blocks the NMDA receptor. Now guys, what is we need to remember? We need to remember the pharmacokinetics of ketamine. Under the pharmacokinetics of ketamine, again we need to remember DODE, in which D stands for dose, O stands for onset, D is duration, E is elimination, T half of ketamine. The dose of ketamine is 1 to 2 mg per kg body weight. Onset is same like propofol, 30 to 45 seconds. The duration is same like propofol, 10 minutes. Elimination of T half of ketamine is 3 to 6 hours. The drug that is having short elimination T half is propofol. Elimination T half is very, very important about all the drugs. Thiopentone 10.4, ketamine, propofol 2 hours, and ketamine 3 to 6 hours. Right? Now guys, coming to the next point of ketamine, that is the effect of ketamine on various systems. Effect on various systems. What is the effect of ketamine on various systems? Remember guys, ketamine is totally opposite of thiopentone. Thiopentone was best friend of CNS, enemy of others. Ketamine is total opposite, means ketamine is worst enemy of CNS. If you just remember this one line, many of the MCQs you can be able to solve, guys. Worst enemy of CNS and friend of other systems. And friend of other systems. Now guys, why am I telling ketamine is the worst enemy of CNS? There should be some reasoning behind it. Why it is the worst enemy of CNS? What can it do? It will increase the ICP. If it is increasing the ICP, can you give ketamine in a patient whose ICP is already increased? No, sir. So ketamine increases the intracranial pressure. It causes potent cerebral vasodilation. So it will increase the ICP. Remember, thiopentone and propofol was causing cerebral vasoconstriction and decreasing, but ketamine increases the intracranial pressure, right? Why it is a worst enemy? The reason is, first, it increases the ICP. Second, it causes epilepsy. Third, it causes hallucinations. Not only it increases ICP, it is also increasing the IOP, intraocular pressure. As it is basically damaging, or it is basically making the things worse for CNS, it is the worst enemy. Hence, as it is increasing the intracranial pressure, can you give ketamine in a patient who is suffering, in a patient who is having head injury? No, sir. Ketamine is contraindicated in head injury and neurosurgery. Next, as ketamine causes epilepsy, it is contraindicated in epileptic patients. Third, ketamine produces hallucinations. Now guys, when will ketamine produce hallucination? During anesthesia or after anesthesia? As the patient is recovering from the effect of ketamine, patient will have hallucinations, delusions, nystagmus, confusion and fear. That is called as emergence reaction. We have seen many of the patients, as they are recovering from the effect of ketamine, or during recovery, I have seen many of my patients. There was one of my junior. He was giving anesthesia to a young lady. He gave ketamine to the lady, and as the lady was recovering from the effect of anesthesia, this lady began to stare at the junior doctor, right? And he was like blushing. It was not a normal stare. She was like staring. She was constantly just staring, and she was telling, "Doctor, you are so nice. Your hair is so nice." This junior was blushing. He knew that his hair were small, but still he was blushing, right? Then slowly this lady, she took her hand towards the junior's cheek, and she told, "Doctor, you look, you are so cute, huh?" And this guy was very happy. We were enjoying this scene. We told the junior, "Please don't blush. It is not the patient who is talking. It is the ketamine that is making the patient talk." So basically, during recovery, the patient will have hallucinations. The patient will have delusion. The patient will have nystagmus, confusion, and fear. These are all called as what, guys? These are all called as emergence reaction. So, as it is already causing hallucination, can you give ketamine to a schizophrenic patient? Yes or no? Never. Ketamine is contraindicated in schizophrenia. As ketamine is causing hallucination, It is contraindicated in schizophrenia. Next, ketamine increases the intraocular pressure. As it is increasing the intraocular pressure, ketamine is contraindicated in glaucoma cases. All worst parts related to the CNS, यानी कि all bad parts, all contraindication to the CNS, hence worst enemy. Then I told you ketamine is a friend of other systems. What other systems? Friend of other systems. ठीक है? Friend of other systems. In that we need to remember respiratory. What does ketamine do to the respiratory system? Ketamine, as it is a friend, it causes potent bronchodilation. Causes potent bronchodilation. As it is producing a good bronchodilation, ketamine is regarded as IV induction agent of choice. IV induction agent of choice in bronchial asthma. In cases of bronchial asthma. Very, very important MCQ, guys. Ketamine is regarded as IV induction agent of choice for bronchial asthma. Next, what does ketamine do to the cardiovascular system? Ketamine is a friend or enemy? Friend है sir. Friend बोले तो what will it do? It will increase the BP and it will increase the pulse rate. It basically increases the BP and pulse rate by sympathetic stimulation. Sympathetic stimulation, right? As it is increasing the BP and pulse rate, it also increases the myocardial oxygen demand. But first, as it is increasing the BP and pulse rate, due to this feature, can I give ketamine for shock-like conditions? Can I use ketamine if the patient is in shock? Yes or no? It is the IV induction agent of choice in shock. IV induction agent of choice in shock. Very, very important, guys. ठीक है? IV induction agent of choice in shock. Apart from that, can you give ketamine for ischemic heart disease patient? Yes or no? And remember, guys, when you compare ketamine with other IV induction agents, all IV induction agents were causing hypotension. Okay? So we are not giving in shock. In shock, we give ketamine. When compared to ischemic heart disease, can you give ketamine? I told you, ischemic heart disease patient can't tolerate extreme changes of the blood pressure, whether it is low or high BP, whether it is low or high pulse rate. What is ketamine doing? Ketamine is increasing the BP and pulse rate, thereby increasing the myocardial oxygen demand. Hence, ketamine, even though a good friend, it is contraindicated in ischemic heart disease. But ketamine is safely given, or ketamine is the IV induction agent of choice for cyanotic heart disease. Cyanotic heart disease. In cyanotic heart disease patients such as tetralogy of Fallot or any other condition, you want the BP to be on a higher side, there you can give ketamine. There you can give ketamine. Okay? So we are discussing about ketamine, guys. Is it clear? Very important. So cardiovascular system. CNS we have discussed, respiratory we have discussed, cardiovascular we have discussed. Next system is muscle. What is the effect of ketamine on muscle? What's the effect of ketamine on muscle? Effect. Ketamine increases the muscle tone. It increases the muscle tone. How about the analgesic property related to ketamine? Ketamine is the only IV agent, only IV induction agent with analgesic property. With analgesic property. Very, very important. Right? And there is no pain during injection. No pain during injection. Right? One more special property of ketamine is a IV induction agent that is having pro-thyroid properties. Which was the IV induction agent which was having anti-thyroid properties? Thyroid, T. So that agent also starts with T. Thiopentol was having anti-thyroid. Ketamine is having pro-thyroid properties. Hence, it is regarded as IV induction agent of choice. IV induction agent of choice in, come on guys, in mixed edema coma patient. Mixed edema coma. Okay, that's regarding what, guys? That's regarding the effects of ketamine on various systems. Right? Now coming to the contraindications. Contraindications, if anyone is asking you, always try to memorize the effects. Try to recollect the effects. With effects, you can remember the contraindication. Remember, effect mein, ketamine was the enemy of CNS, friend of others. Worst enemy. So worst enemy say all contraindications. Contraindications of ketamine all come from the CNS. Contraindicated in head injury, neurosurgery. Apart from that, schizophrenia, epilepsy, glaucoma, you don't get ketamine. Apart from that, other contraindication is it is contraindicated in ischemic heart disease and ischemic heart disease. Okay, it's contraindicated in ischemic heart disease. I told you the complications of ketamine during recovery. What will happen, guys? During recovery, patient will land up into this emergence reaction. What is that emergence reaction? We have already discussed hallucination, delusion, nystagmus, confusion, and fear. Right? So contraindications all come from the CNS. One extra contraindication is on the CVS. That is what? Ischemic heart disease. Ketamine is contraindicated in ischemic heart disease. Okay? That's regarding ketamine. Coming to the last IV induction agent, that is called as etomidate. Etomidate. Now guys, regarding etomidate, you don't have to remember the conventional method like introduction, pharmacokinetics, effects, side effects. No. In etomidate, what we need to remember, just 2 or 3 important points. First of all, etomidate is an imidazole derivative, right? Why is etomidate commonly? Remember, it's an imidazole derivative and it's a milky white solution. Same like propofol, right? Most important point of etomidate that we need to remember is etomidate is the most cardiostable IV induction agent. Now guys, a patient is suffering with ischemic heart disease and you're having options like thiopentone, propofol, ketamine, etomidate. Which one will you choose? First tell me, why don't you choose thiopentone? Sir, thiopentone decreases the BP, increases the pulse rate, hence not used. Propofol decreases the BP, decreases the pulse rate, hence not used. Ketamine increases the BP, increases the pulse rate, hence not used. Etomidate is the IV induction agent of choice for ischemic heart disease or coronary artery disease. Why? Why? Because neither it increases the BP nor the pulse rate. It maintains the BP and pulse rate. It maintains the BP and pulse rate normally. Okay? So that's why etomidate is the most cardiostable IV induction agent. That is the only good point of etomidate. The bad points of etomidate starts with what? As you're giving the injection, the bad point of etomidate starts. It's a painful injection. It's a Painful injection. Second point you have to remember. But guys, is a painful injection being a new thing for you? No. Almost all IV induction agents are painful except ketamine. So the back points of etomidate are it's a painful injection. Apart from that, you can't give etomidate as a long-term infusion. If you give etomidate to a patient who's to any patient on long-term infusion, what will happen? It will inhibit an enzyme called as 11 beta hydroxylase, leading to adrenal suppression. Very, very important. That can cause deterioration of the patient's health. That can cause rapid deterioration of the patient's health. And etomidate, last point of etomidate that we need to remember is, etomidate is the only IV induction agent that causes nausea and vomiting. Come on, guys. Which was the IV induction agent that was preventing nausea and vomiting? Propofol, antiemetic. Etomidate. So, just a summary of etomidate, guys. Etomidate, one good point is it's the most cardiostable IV induction agent. Hence, use it any heart diseases. But the back points of etomidate are it's a painful injection causing nausea, vomiting, and on long-term infusion it causes adrenal suppression. Okay, that is regarding what, guys? That is regarding etomidate. So these were the 4 IV induction agents that we have discussed. Okay, guys? So coming to the last IV induction agent, which is called as methotrexate. Now guys, methotrexate is a IV induction agent that belongs to barbiturate category. That belongs to barbiturate category. Okay, it's a barbiturate. Now, apart from that, you also need to remember it's a short-acting IV induction agent which is commonly used for electroconvulsive therapy. It is used for electroconvulsive therapy, right? Next, we'll solve some of the MCQs, guys. A 16-year-old male patient presents to the surgical emergency department with right hypochondrial pain and fever for the last 4 hours. He is a known case of asthma. The attending doctor, after evaluation, decided to do an appendectomy due to a suspicion of acute appendicitis. The anesthetist so appendectomy is done under normally spinal, but he is posted for general anesthesia. So anesthetist decides to go for propofol. What is the role of egg lecithin in propofol formulation? Egg lecithin in propofol formulation. Come on, guys. This was a previously asked question. Come on. Egg lecithin role. Egg lecithin acts as an emulsifying agent. It acts as an emulsifying agent. Right? Next, a 22-year-old female presents in a surgical emergency with vomiting, abdominal pain, and constipation for 3 days. Examination reveals abdominal tenderness with absent bowel sounds. Looks like obstructed bowel. X-ray shows air under the diaphragm, intestinal obstruction case. She is suspected to have a typhoid perforation. She is planned for emergency laparotomy under general anesthesia. The thing, remember first few lines are usually not necessary. Now, considering her cardiovascular instability, etomidate is used for the induction agent. What are the complications that can arise following the use of etomidate? So basically, cut short this question. The question is asking you about what is the complication of etomidate use? Etomidate use can cause what in the patient? Post-op delirium is not common with etomidate. It is common with either ketamine or either with sevoflurane. Okay? Chest wall rigidity is not with etomidate. Chest wall rigidity is commonly seen with opioids. The most common side effect of etomidate use is adrenal insufficiency. Whenever it is given, it can, whenever long-term infusion of ethambutol can cause the patient or land of the patient into adrenal insufficiency. What could be the IV anesthetic agent of choice for a child who is scheduled for emergency bronchoscopy? ठीक है, emergency bronchoscopy. I'll give you options. The options are not given here. I'll give you the options. The options are propofol, ethambutol, thiopentone sodium, and last ketamine. Come on, guys. Which could be the IV induction agent of choice for emergency bronchoscopy? Emergency bronchoscopy means the patient might not be in an NBM status. They are just going for an emergency bronchoscopy for, might be due to any other condition. Okay. So if at all you give thiopentone or propofol or ethambutol to the patient, all will basically blunt the protective airway reflexes. Okay. One way or the other way, they are blunting the reflexes, and the patient will be at risk of aspiration. The only IV induction agent that is not blunting the protective airway reflexes is ketamine. Whenever you give ketamine to the patient will be unconscious, but he will be aware of the things. His respiration will be normal. He won't aspirate. So in this case, the answer is ketamine. Emergency procedures or any emergency surgeries, you can go for ketamine. It does not blunt the protective airway responses. Next, guys. A 40-year-old female is posted for radical mastectomy secondary to the breast lump. Biopsy reversed ductal carcinoma, past medical history significant for hypertension. She takes losartan and has moderate mental stenosis for 6 years. Smokes also, drinks also on weekend. On examination, her temperature is normal. Okay, her blood pressure is 110, pulse is normal. The cardiopulmonary examination is normal. ECG and chest X-ray are unremarkable. The IV induction agent, the induction of anesthesia is done with propofol. Anticholinergic medication with sedative properties is being selected for this patient. So basically, he is asking, now surgery hasn't been started, guys. Before surgery, in the pre-medication, an anticholinergic drug is used for the patient, which is having sedative as well as antiemetic property. Which could be the best option? Come on, guys. In the pre-medication, which is the drug that is having both, which is having anticholinergic, antiemetic, and sedative property? In pre-medications, we give the patient 4 A's. Okay? Antiemetic, anti-anxiety, anticholinergic, antibiotic. In the anticholinergic, which anticholinergic is having antiemetic and sedative property with anticholinergic property? The answer is hyoscine. Hyoscine exhibits all 3 qualities. Okay. That's regarding what, guys? That's regarding the general anesthesia.